All right, thank you for the kind invitation to present here today. My talk will be about diabetic retinopathy, screening programs for internal medicine specialists. The worldwide diabetes prevalence in 2010 was 285 million people. By 2040, the number of people with diabetes is estimated to reach over 642 million people. The growing epidemic of diabetes will spare no nation. It is a global health problem that will affect all countries, all regions, and the greatest increase will be seen in developing countries. In the Middle East and North Africa, it is expected that by 2040, 72 million people will have diabetes. That's more than North America, South America, and Africa. In 2021, Egypt has 11 million people with diabetes, ranking it 10th worldwide. By 2020, this number will increase to around 20 million people. Egypt is also ranked 5th worldwide with the number of people with undiagnosed diabetes, with approximately 6.8 million people. Diabetic retinopathy is the most frequent microvascular complication. It affects half of the diabetes population at any one time. Diabetic retinopathy is also the leading cause of vision loss in adults aged 20 to 74, with 5.4% of patients with diabetes having moderate to severe vision loss at the time of their diagnosis. This map shows the prevalence of diabetic retinopathy per region. The Middle East and North Africa had the second highest prevalence of diabetic retinopathy in their diabetic populations. It is estimated that right now the prevalence of diabetic retinopathy and vision-threatening DR is 33 and 8% in patients with diabetes in the MENA region. That means approximately 3.6 million Egyptians have diabetic retinopathy, and 900,000 are estimated to have at least vision-threatening diabetic retinopathy, potentially needing treatment. These numbers are projected to double by 2045. Diabetic retinopathy can be asymptomatic despite the presence of advanced disease. Its presence is identified only with retinal imaging or dilated retinal examinations. All individuals need retinal examinations annually and early detection with timely treatment, preventing the risk of vision loss from DR. This is a normal eye with no diabetic retinopathy. Compare this to an eye with advanced diabetic retinopathy. Notice the extensive neovascularization. You'd be surprised to know that this patient had a vision of 6/6. However, vision loss can be quite rapid with patients developing massive vitreous hemorrhage that can impair vision tremendously. Sometimes advanced fibrosis and traction can develop that can lead to vision loss, which can be irreversible even with surgical intervention. The key is identifying these changes early, before the patient starts to develop vision changes. Early intervention can save vision. Now, these are the current AAO guidelines for diabetic retinopathy screening, which you are all aware of. However, despite many years of widely available guidelines, large proportions of patients with diabetes do not receive the minimum annual dilated eye exams. Even in countries such as France and Italy, uptake is around 50%. Unfortunately, we do not have data from Egypt. So how do you screen for diabetic retinopathy? There are several different methods. Dilated fundus exams, which we are all familiar with, happens in the ophthalmologist's office. They're quite expensive, very long wait times in busy clinics, and require that the patient is dilated. Unfortunately, unless performed by a retina specialist, these exams tend to have a low sensitivity and poor specificity. In programs that have adapted this, there's unfortunately poor uptake, with less than 20% of the targeted population being screened and poor year-on-year retention. The second is non-mydriatic fundus photography. So we use cameras to take pictures of the eyes of patients with diabetes. Now, this is the older Topcon camera used in the 80s, 90s, and early 2000s, and in some centers still here in Egypt. It can only take a very small area of the retina, a very small part, around 30 degrees with a single image. And we would then have the patient look up, down to different sides to acquire the images of a large part of the retina. This can take a very long time, almost 5 to 10 minutes, depending on the patient's cooperation. Now, non-mydriatic fundus photography involves taking around 1 to 3 fields of photos, and screening is done by color photos and not fluorescein angiography. Has a bright flash, which is quite uncomfortable. Unfortunately, these cameras, they tend to have a high ungradable rate, meaning that around 1/5 of the images acquired are such poor quality that they cannot be assessed. They also have a sensitivity and specificity that is linked to the number of fields imaged. Unfortunately, the greater number of fields, the more the time needed, and the greater the patient discomfort. More recently, we have ultra-wide field imaging. Just a reminder, this is the area acquired by the classic fundus cameras. And this is an image acquired by the newer ultra-wide field cameras. This is a tremendous increase in the area of the retina that can be visualized. These cameras allow us to visualize over 80% of the retina in a single image in less than a second without having the patient look at different directions. And this massive area is imaged through an undilated pupil. A large study in the US compared between non-mydriatic fundus photos, the classic technique used, and ultra-wide field images in an active diabetic retinopathy screening program. Only 2.6% of images acquired by ultra-wide field images were ungradable. Contrast that to 27% using the classic non-mydriatic fundus photographs. Ultra-wide field imaging also resulted in a twofold increase in detecting more diabetic retinopathy, meaning that more people with disease were identified and in turn referred. You see these microaneurysms on the far edge of the retina highlighted in the red box? These would not have been previously seen using the classic cameras, which can only image the area in the blue circles. It was recently found that these peripheral lesions are associated with a 2 to 3-fold increased risk of progression to proliferative diabetic retinopathy. Also, more than 50% of the new vascularization is found in the retina periphery. Finally, I'd like to talk to you a few minutes about the initiative between iCare Ophthalmology Center and the Bethema Institute Jaws and Diabetes Center, Harvard Ophthalmology. It involves establishing a reading center to grade the ultra-wide field images. As part of this collaboration, 6th graders will be trained and certified. Quality control will be maintained by re-evaluating the sample of the graders' images over the next 2 years. So how will this work? Well, the most important part of the process is you, the internal medicine doctor. The patient is more likely to see you than the ophthalmologist. The patient is then referred to acquire undilated images using the Optos. Images are then read in the reading center by the trained, certified Jaws and Harvard grader. The report is then sent to both the patient and the referring internal medicine doctor. At no point so far will the patient have direct contact with an actual ophthalmologist. We know from previous studies that around 80% of patients in screening programs will have no diabetic retinopathy or mild NPDR. Those patients do not need a formal eye exam and can be imaged annually. 20% of patients will have vision-threatening diabetic retinopathy. The internal medicine doctor will receive the report and at that point, refer the patient to the ophthalmologist of their choosing. We believe that this has many advantages for the patient, including low wait times, no dilation, no fluorescein dye, and the relationship will mainly be with the internal medicine doctor who the patient trusts. So in summary, screening programs will require cooperation of internal medicine doctors and ophthalmology. Ultra-wide field imaging is heralding a new era of DR screening. 80% of the retina in less than a second with no dilation. However, to ensure accurate evaluation, a designated reading center is needed. The collaborative project between the Bethema Institute, Joslin, Harvard University, and iCare will train and certify graders, providing trusted quality control reports. 80% of the patients will never need a formal eye exam. Only 20% of patients screened will require evaluation by an ophthalmologist, and it is the internal medicine doctor who will coordinate the referrals. Thank you very much for the kind invitation. It was lovely speaking to you today, and I'm very happy to be here talking to you all today.